Hi, everyone. I'm Ashley Bassett.
And I'm Catherine Logan.
And welcome to Overtime with the Sports Docs. So on each of these mini episodes, Catherine and I chat about a new topic or a new surgical technique in the field of sports medicine. We'll give you our quick take on this topic and the recent data, and whether or not we think that data will be impacting our practice. If you're looking for a trusted name in osteochondral allograft transplantation, look no further than JRF Ortho. With a stellar track record and a reputation as the leader in fresh osteochondral allografts, JRF Ortho is here to elevate your practice to new heights.
JRF Ortho has proudly distributed over 25,000 allografts worldwide, making a significant impact in the field. Their passion for this industry goes beyond the numbers. It's about helping patients and fulfilling their mission of improving people's quality of life.
But that's not all. At JRF Ortho, they understand that superior customer care is crucial. They aim to give you one less thing to think about so you can focus on what matters the most, your patients. And they make ordering JRF Ortho easy. They're committed to accommodating your needs, delivering allografts on your terms.
You're in control. Choose your scheduling option, whether it's specifying a surgery date, providing a date range, or just requesting the earliest available allograft. Your preferences are their top priority, so prepare for success. Order with JRF Ortho and take control of your orthopedic journey. Today we're talking about medial meniscus posterior root tears, and we will be reviewing an article from AJSM last month. Its title was Medial Meniscus Posterior Root Tears Lead to Changes in Joint Contact Mechanics at Low Flexion Angles During Simulated Gait. This study was performed by Dr. Sabrina Strickland, friend of the show, and her team at HSS. We will also reference an older article from January 2020 in AJSM, and it nicely compares the different treatment options for medial meniscus root tears. As always, links to the papers that we discuss are going to be found on our website, so that's www.thesportsdocspod.com.
So before we get into our papers today, we wanted to talk a bit about meniscus root tears. So first, what is a root tear and how does it differ from all the other meniscus tears that we've spoken about on this show? So meniscus root tears are defined as either bony or soft tissue avulsions or radial tears within 1 centimeter of the meniscus root attachment. So if you're watching this on YouTube, you'll see a nice illustration showing the different types of root tears from a paper by Laprade in 2015. So because this tear pattern effectively compromises the meniscus hoop stretches by detaching it from its attachment site, complete root tears are biomechanically equivalent to a total meniscectomy, leaving the patient with no shock absorption capacity, and therefore all axial load gets transmitted to the cartilage surfaces. So therefore, it makes sense that these tears are increasingly being recognized as a cause of morbidity, but also associated with development of early arthritis. So more on that in a little bit.
All right, so let's talk about the mechanism of different root tears. So medial and lateral anterior root tears are typically iatrogenic, meaning like caused by a surgeon, or occur during ACL tibial tunnel reaming and IM nailing of like if you're doing any tibial shaft fractures. The lateral posterior root tears are often seen in association with ACL tears and tend to occur with a rotational injury while the knee is flexed. And medial posterior root tears, on the other hand, they're a little bit more like degenerative in nature, and they usually occur low energy mechanism wise, often when the knee is deeply flexed while weight bearing. So if you're like squatting to pick up an object off the floor.
So yeah, as Catherine alluded to, these tears are commonly degenerative, and they're often seen in middle-aged women, particularly those with varus malalignment, so bowing of the knees, and those with an elevated BMI. So patients may report an acute injury with a pop, mild swelling, difficulty bearing weight due to pain or instability, but up to 70% of patients cannot identify an inciting event. And typical meniscus symptoms like clicking or buckling are only present in about 10 to 15% of these patients. An exam is similarly limited, with positive findings only in roughly 50 to 60% of patients. So things to look for on exam include posterior pain with deep knee flexion and joint line tenderness. In the literature, there's also something called the extrusion test that's demonstrated, which is described as palpable meniscus extrusion when a varus stress is applied to a knee in full extension. I don't find this as reliable because most of my patients that have these kind of tears, they tend to be larger individuals. And so I'm not sure I can really palpate an extruded meniscus, but Catherine, what do you think?
Yeah, no, I mean, even still, like, I feel like even if the BMI really isn't that high, let's say it's like 30, right? Yeah. And that's not like that's just a little extra
Yeah.
like soft tissue envelope. I still
Mhm.
don't think you can palpate that. Like it would have
Okay.
to,
Yeah.
I don't know.
Yeah.
Yeah, so I can't say that's a test that I've ever
Yeah.
utilized.
Mhm.
But
Yeah.
I think, did you ask me another question too? I feel like you asked something
Yeah.
else.
So I kind of had to do with your population. So, I
Yeah.
was alluding
Oh,
to
okay.
my population in New Jersey. Gosh, I like all my New Jersey people that are listening to this. I tend to be, a little bit maybe less active daily as your population. And so I'm
Right.
maybe dealing with people that are more of a generative picture, maybe slightly higher BMI, but you have a bit more of an active population. Are you seeing this similar kind of
Yeah.
patient type for this tear, or are you seeing a different population?
No, I would say I'm seeing the same exact patient. I'm just
Oh,
not seeing a high frequency, right?
mm,
So I'm not seeing this in like the healthy, active, like as far as the medial meniscus posterior root tears. I can't even think of one recently that I've seen in like sort of that active, fit sort of
mhm,
individual. I'll see something different. And that maybe it's medially sided, but like it's just not this pattern.
yeah,
But when it does come into my office and I am seeing it, I would say they are the, you know, quote unquote sedentary sort of population, meaning like they're just doing less. Maybe they're active in the sense that like they do a little bit of hiking or gentle hiking, but they're not doing
mhm.
like pretty intense stuff. So probably the BMI, and
I was
age
just going to
has
say the studies have shown that a BMI is a risk factor for development of posterior root tear. So because perhaps your population may have a lower overall average BMI than my population, perhaps we're seeing that because I feel like they come in waves, like distal biceps tears.
yes,
Like I feel like I just repaired 3 medial meniscus root tears, and then it'll be like months before I
right.
see another one. Oddly, this is going a little bit off, but I just think it's really interesting to share. I just did a medial meniscus isolated root tear repair in a 12-year-old. He fell out of a tree
What?
playing, yeah, I know. He fell out of a tree playing manhunt. He wouldn't mind me sharing the story. Landed awkwardly on his knee, kind of felt a pop. People thought it was an ACL, sent him for an MRI. ACL is totally fine. All the ligaments are fine. Complete avulsion of the medial meniscus posterior root. I was like, they
Bizarre.
asked me, like, does this need to go to pediatrics? I was like, no. It's going to
Yeah.
be the same sequence as in an adult. But I was like, I've never seen this before. The only root tears I've seen in that young are associated with an ACL. Like how crazy is that?
And it wasn't like discoid or anything like that in the
No,
lateral?
no discoid lateral, and it was a medial root
Yeah.
tear, not lateral.
Yeah.
Yeah, it was
Okay.
very very odd.
That is one to write up.
That's a really good idea. I really should because at first I thought, maybe it's an MRI overcall. I'm going to get in there and not see it. I went in there and I lifted it up, and the whole thing just lifted right up.
Yeah.
But
Write up
I
that.
must say it was kind of nice because
Yeah.
usually they're
Oh, there's so much space.
tight, exactly, tight joint space. You like glance at the cartilage and it like
Yeah.
falls right off like in a root tear. But like with this, I feel like it was like wide open space, healthy cartilage. I was like, why can't they all be like this? This is great.
That it came together so nicely.
It really did. It was beautiful.
Yeah.
That's the one I'm going to show when I do like meniscus root tear toss. Like it always looks like this.
Yes. Great. Yeah.
Exactly. So we talked
No,
about the
I think that's a
extrusion.
good one to write up.
I will. I think I will
Yeah.
now. I'll write it up because it's. I'm now that you say you're like, whoa, that's
Yeah.
bananas. I've never seen that, and you have a very active
Yeah.
population. I think I will write it up.
Good.
Awesome.
Okay, good.
Yeah.
Um,
So we
Go
talked
ahead.
about extrusion tests and about how we don't
Yes.
find that reliable. What are you looking for on exams? Like, is it kind of the stuff that I rattled off? Is there any special tests you're doing to see if it's like a posterior root versus like a classic posterior horn medial meniscus?
No, I think I'm always quick to get some more advanced imaging. I think if
Mhm.
someone's coming to the orthopedist, they're generally already, like I've sort of failed some conservative management.
Yeah.
They're there for a reason, and it doesn't always come up in an exam. I think more than you said that they just have like some joint line tenderness or like
Mhm.
maybe even some like generic medial posterior pain. But
Yeah.
I'm quick to order the imaging. I hate blowing. You always hear all these stories about like, oh, someone blew me off, and we've had
Yeah.
this for 6 months, and it's just unnecessary. So
I agree.
MRI for me.
Yes.
Yeah.
Awesome. So what are you looking for
Um,
on that MRI?
okay. So MRI wise, I think so. For actually on Dr. LaProd's website, so we're talking about Dr. LaProd as well. He had the way I learned to look through MRIs for root tears, among other things, is on his website. He actually has tutorials So
Wow.
you can like sort of go, and it's for the public, and you can go and he will like walk you through, hey, I'm looking at the coronal of, this MRI, and this is how I find a root tear, and he walks you through it. So for me, I find as far as like which slice is like most helpful,
Yeah.
it's generally for me a coronal, and like, I'll go, back and forth, front to back a few times, but you're really just like kind of looking through like at
Yeah.
that root as it gets into that posterior attachment into the tibia. So,
Mhm.
we will put it like a little link to
Yeah.
that on the website, and I'll highlight it on YouTube.
Awesome.
Anything else that you're looking at? Is there a specific slice that you find more helpful?
No, I think you said it perfectly. The coronal, to look for that extrusion, to see how extruded it is for kind of surgical planning of what I think I may have to do when I get in there. I think the MRI, obviously, to look for cartilage as well too. If it's like complete, osseous edema, I know you can see with root tears, but if it's like osseous edema, full thickness cartilage loss, osteophyte formation, the meniscus is literally completely entirely in the meniscotibial gutter. They may have a root tear, but are we going to do anything about that? And then that ghost sign that gets described that sometimes I see, depends on the cut, right? Like if you get the cut, it's like meniscus gone. And so if you're watching this on YouTube, we'll show you what we mean by ghost sign. It's essentially the normal, black appearance of the posterior triangle of the medial meniscus disappears in one of the cut. And that's basically effectively the transection or the loss of that meniscus in that area. And so that is indicative of a posterior root tear. So definitely looking for that if I can see it on the sagittal MRI. But yeah, that's pretty much it. Just trying to, as you said, I think the coronal is the most helpful.
Yeah, I think so too.
Awesome.
Did you want to talk a little bit more about biomechanics?
Yeah, I think it's a good segue into talking about that article. So we kind of wanted to talk about why root tears are so different than regular tears, right? So why are we talking about potentially surgery for them versus other degenerative meniscus tears we're kind of leaving by the wayside? So the paper by Dr. Sabrina Strickland, as Catherine said, who's a friend of the show, check out episode 44 if you want to hear her talk more about patellofemoral cartilage disease. And her team at AJSM, it was a laboratory study that she did of 6 human cadaveric knees, and they did a simulated medial meniscus posterior root tear. And then they looked at the peak contact stress and the contact area under simulated gait. And they found that the peak contact stress was increased about 20 to 37% of the gait cycle in the setting of a posterior root tear, and 16 to 60% decrease in contact area along the gait cycle, with knee flexion angles less than 15 degrees. So that's a lot of information I just threw at you. What does that mean? I think the biggest takeaway from this paper is that these issues occurred at low flexion angles. So a lot of the older studies were showing like, oh, deep knee flexion, that's when you really have this. This is at a normal gait cycle. Over 50% of the gait cycle, it affected the contact area at really low flexion angles, which just kind of further highlights the biomechanical detriment of leaving these tears alone and how they can be associated with increased joint stress and can be associated with joint degeneration, therefore. So, Catherine, what do you take away from this? Like, is this make you more likely to try to, hashtag save that meniscus, or what are your thoughts?
I think it's all about counseling, because you kind of add it with, and I'll try and find the paper and post it as well. But there was another paper, I remember that when I was a fellow, Dr. LaPrade shared with us, where it looked at if these are ignored, or, they saw, somebody saw it during arthroscopy, like, oh, they have a root tear, and just kind of let it be, just, I'm not going to fix this kind of thing. I believe the average time to conversion to a total knee was 5 years for these degenerative medial meniscus posterior root. So I think you're sort of counseling these people like, okay, we can ignore it. We can not do anything about it if they're a degenerative, low demand type person. But this is generally what we know natural history is going to result in. We're going, you're going to accelerate your path to a total knee. We can try and fix it, knowing that in this setting, the repair is very different than your 12-year-old.
Yes.
Are we going to really get an anatomic fixation? Are we going to is the meniscus already extruded? But I think it's telling us that, without doing something, we know that biomechanically this is not good for our knee. But I think in the setting of the arthritis or the degenerative, like, we also can't, believe that our repair is going to make it like, so now all their contact forces are totally normalized.
Yeah, exactly.
Yeah. Is that sort of how you see it, or you counsel a little different?
Absolutely. And I think when you were starting to mention the LaPrade paper, I thought you were going to talk about this one that I kind of stumbled across when I was looking at meniscus root papers, which is looking at anatomic versus non-anatomic meniscus root repair. So, I feel like it's not just enough to attach it to bone. Like you have to put it back where it sheared off.
Where it belongs.
Exactly. And so sometimes, and we'll talk a little bit about treatment, like how you do the repair and all that stuff. But I feel like sometimes like you do your releases, you try a centralization, you try to get it over and you can't get it over. I mean, in that case, you can try your hardest, you can attach it where that is, but I don't think you're restoring those hoop stresses and really affecting that contact area and that contact stress. And so we're kind of patting ourselves on the back for fixing these, but are we really helping that patient restore their biomechanics? And I think that paper said no, that we are not.
100%.
But I think you kind of alluded to something really important, which is like the different treatments and how that can affect the long-term prognosis. Like if you do nothing, they progress to TKA pretty fast. And that's the paper we were talking about in 2020 with Dr. Aaron Critch, also a friend of the show. Check out episode 42 to learn more about that. But they looked at meniscectomy versus leaving it alone versus doing a repair. And meniscectomy had the worst outcomes. And so I feel like sometimes people like do a scope and they're like, oh, if I can't repair it, I'll just clean it out. Like that's almost worse than just leaving it alone. So like, what are your thoughts? I think I know the answer to this, but like, would you ever if you attempt a repair and you can't do a repair, like what are you doing for that? Are you doing like a partial repair? Are you trying to get it over? Like, what are your thoughts?
I think I wouldn't just do like a meniscectomy and sort of just like wash my hands and, be done with it. I would definitely try and do a partial repair. But I do think it's all about the counseling. But and I think part of that counseling is even that scope alone where you're getting, water in your knee, your quad shuts down. Like, so I also wonder the people that have the meniscectomy, are they worse because they basically just got atrophied post-surgery and maybe no one told them that you really got to do rehab no matter what, even with the simple surgery that you have to like beef up your legs again. Yeah. So I wonder if that's part of the trajectory. But I think it's all about, hey, this isn't an easy problem to fix, like really counseling that on the front side. And so that, because I think a lot of the disappointment after is if they just thought this is all going to be perfect or a meniscectomy, no big deal. I don't have to worry about recovery. Like, it's a tough problem for sure.
Yeah, absolutely. But I do think it's great that this data is coming out showing that we can hopefully slow the progression of the arthritis and delay the need for a total knee. That paper, I feel like it's helpful because I think a lot of times people will see root tears and they'll see some arthritis, they'll see some subchondral edema, and they say, it's degenerative, there's nothing to do. And then, I don't know, by the time it like reaches my clinic or your clinic, maybe it actually is irreparable at that point. So I feel like the more primary care doctors know or PTs know or just people in the community know that these are tears that we would be considering a repair, even just to buy this patient maybe 5 more years before their total knee replacement as opposed to 3 years and going on to need it. I think it's beneficial. But you're right about the counseling. I mean, I don't know, but you will talk about this in a little bit, but I mean, they're non-weight bearing for a period of time after the surgery. They're in a brace. They're in therapy for a long time. Yes, it's a long run for a short slide. They don't do well with that, right? So it's definitely counseling as you highlighted.
The other thing I just thought about was I wonder, like the Misha Moxymed sort of, neither of us do that. But that's something I think this summer at AJSM we should definitely, kind of investigate a little bit more. I know we talked about like Gamal and Sabrina, who knows.
Absolutely. But, no, definitely. I actually had, so I was supposed to do a lunch with one of their reps just to talk about it because I do think it's a great solution for that active patient that you and I are seeing that just like cannot handle the idea of a, total knee and, maybe just it doesn't want a UKA and can't have a meniscectomy or an osteochondral allograft transplant or a MACI. They're just not, they just don't qualify for that. I think it's a really great option for them. Yeah. So definitely something we should talk about more at AJSM.
Yeah, we'll figure that out. Yeah, awesome. Curious. But yeah, I would say, in sort of summarizing this all, like Ashley, like what are your contraindications for some that you'd say like with these medial meniscus sort of posterior root tears? Who would you say definitely no surgery?
Yeah, so I think severe arthritis is probably the number one for me. So severe, like that Kellgren-Lawrence that was described in that paper that by Dr. Critch,
3, 4.
Greater than 3 or 4, subchondral collapse, just like badness on X-ray, right? We all know when we see it, we look at it and we go, there's no more meniscus there, right? If I put it there, it's just going to get squished back out, right? It's going to get torn up because of that arthritis. Malalignments, so greater than 5 degrees of varus malalignment, unless I'm fixing it. But again, now we're getting into like, are we really going to be doing an HTO and a medial meniscus root repair and someone who's, with a degenerative meniscus tear in a middle-aged individual? I don't think so. No. And then instability, unless of course that's addressed. So like, again, that's more like the lateral root plus ACL, like you got to address both of them. But if someone has a chronic ACL tear, I'm not sure that repairing their meniscus, unless we also are addressing their ACL, is really going to be beneficial for them. But what about you?
No, I think same. And then obviously I'm sure we both agree, these like lateral meniscus traumatic, root tears we're addressing. So there's really, no reason not to. So I think the chronic ones are the ones that have a little bit of like, they get a little sticky, but I think the lateral, it's a really clear indication.
Yeah. So Catherine, I'd love to hear your surgical technique. How are you addressing these?
So generally, if it is one of those like acute sort of lateral, we have a little bit more of an opening. I'm using a tunnel technique. And I've kind of used a couple different guides because I'm sure they all have room to improve.
Yes. Yes. And it's so hard. We've solved so many medical things, but I completely agree. The root repair guide is still that missing link.
It's a missing link. But, I think there are some newer ones coming out and some lower profile. And I also have heard Stryker's coming out more with like a new, as far as like a passer, like suture passer for the meniscus. That is supposed to be a little lower profile. But yes, ideal world, I would like to do a tunnel technique. There was a paper that I will also post. It actually came, I want to say it was Dr. Dragoo, but he compared like root to all inside and had some really good results for all inside. So meaning if you have those tricky ones that are medial that you're like, that guide is not getting back there unless I'm putting like a trough through the cartilage, like it is just too tight. I'll find that, Ashley, but where it was just saying, yes, you can sort of approximate if there is a little bit of tissue, obviously if it's avulsed off, but that's not generally what those degenerative ones look like.
Yeah.
But if there is some tissue that you can sort of reapproximate, he had good outcomes with that, doing an all inside technique. So I have done that before for those like degenerative medial ones that you're really not going to have an easy time getting a guide back there. Yep. And if you are, you're generally like, need to rough up the cartilage on the way, and it's just not worth it.
Yeah, I completely agree.
Yeah, go ahead.
No, I think I completely agree. And when you were talking about Dragoo's paper, he also had another paper where he described putting like that all inside, like I'm going to use a brand name here. I'm not saying he uses this, but like a Fastex, just to kind of like anchor that posterior horn to like the capsule, and then also doing like the tunnel, or as you said, like a side to side, like using a knee scorpion and tying it just to give kind of that extra stability. Right. And that was an old paper. I think now we're talking about the centralization stitch, which I will do if there's a lot of extrusion, but a lot of times I can get enough mobility of that posterior horn just by removing the adhesions underneath the meniscus. So I'll just take arthroscopic scissors and just like snip, and then along the top and kind of free it up. And I feel like I can get it back on and I'm not having to do that centralization stitch, because I do worry about restricted meniscus mobility. It's already, you're already kind of, funking with the anatomy a little bit. I don't know that I would add a stitch into something that's not torn in that body of the meniscus. But what are your thoughts on that? Are you doing a centralization stitch in a lot of your cases?
Yeah. No, definitely not. No. Like, I think same thing. Like, it's harder, I think, to free up a lot of that soft tissue, but I do think that gives you a more of like an anatomic repair, like LaPrade said.
Yeah, absolutely. I think that's really key. And then another thing that I feel like took me a while to start to incorporate in, but pie crusting the MCL.
Yes.
Just to open up that joint space, which I always find like tricky to do. But once it like fully opens, you're just like, it's so much easier to get into that area without buggering up the cartilage. And then there's some papers, don't quote me on it, I'll have to search and find those papers for you, but that look at improved healing because the stress on that compartment is less because it's not as tight because you've released that, superficial MCL. So I think that's really a good pearl for people to consider as well.
I do too. Yeah. I actually did that today. So
nice.
I think that helps.
Awesome. So
Um,
then for
okay,
post-op,
so post-op.
yeah,
Yeah.
what are you
This
doing?
is probably the strictest I am. As far as meniscus, I've gotten a little bit more liberal when it's like a smaller vertical tear, like peripheral,
Mhm.
but I still keep them at 6 weeks. And I do let people just like put their toes down. So like a toe
Mhm.
touch, just for a little bit of balance. It's just so icy and snowy all the time. Like I
Yeah.
think it's really hard for people.
Yeah.
And mechanically, I feel like a little toe touch feels okay for me.
Mhm.
But I will say early on, I was strictly non, and I've just gotten a little bit more liberal there.
Yeah, I am very, I mean, I toe touch, I'll let them rest the foot on the ground for balance purposes,
Yeah,
but I do so effectively like non-weight bearing for
yeah,
6 weeks.
yeah.
And then I'm curious to hear your motion restrictions because it's interesting. Like, remember how we were talking with Yoni, how like I
Yeah,
did like a literature search trying to come up with PT protocols, like trying to use evidence-based medicine. And somewhere along the way, I found that like passive motion, you don't really need to limit flexion too
mhm,
much. But
yeah,
like I just don't understand how that's true because I would think hyperflexion like beyond 90 degrees in the early phase would increase the pressure through that posterior horn.
yeah,
So I'm curious to hear your approach. Do you
yeah.
limit them for a period of time
I
or
do
is it
limit them for
has
2 weeks,
only for
like
2 weeks?
2 weeks. So
Okay.
2 weeks, I say 0 to 90 only. Part of
Yeah.
that is I just want like the posterior sort of aspect just to be like quiet, quote unquote
Yes.
quiet. Like
Hmm.
I do feel like even if the repair is going to be fine, by doing passive motion past 90 degrees.
Yeah.
And um, with the roots, I do feel like there's probably some pressure,
Yep.
or some like too much tension. But I
Hmm.
also just feel like sometimes that just incites a lot of discomfort.
Yeah.
And then the next day, what I don't like when people's hamstrings get a little irritated, and whether they're just sort of like there's a little posterior swelling and their hamstrings are ticked off, it
Yeah.
affects their extension because they
Yep.
just don't want to go fully straight because they just feel better with a little soft flex in their knee. So
Hmm.
it's a little bit about the repair, but I also just want to keep that posterior area like quiet so they love going
Yes.
into extension.
That's really important. I mean, full extension is key, like, and that's especially with pain posteriorly, people aren't going to
Yeah.
want to do that. So I think that's really
No,
important.
they just
And then
want
I
that
think
pillow under their knee.
exactly. And I think so it's so funny because I used to do 90 degrees and then I like backed it or I used to do 90 degrees for 2 weeks. Then I increased it to 4 weeks because I was scared. And then I backed it down to 2 weeks because everyone gets stiff.
Yeah.
Because the problem is like, these are degenerative. They have some compromised cartilage, even in like, I mean, not the 12-year-old that I
Yeah.
did, but everyone else has compromised cartilage. They're going to get stiff. And so
For
I
sure.
think like, even if you say, bend to 120 by 4 weeks, like they're not getting a 120 at 4 weeks,
Yeah.
So I think restricting them further, like to 90 degrees to 4 weeks is just setting them up for arthrofibrosis. So I still do 90 times 2 weeks, but I was kind of hemming and hawing. I was going back and forth based on the biomechanical data, but I really think it's still the right thing.
Yeah, I think you're
awesome. Good. I'm glad you agree. Awesome.
cool. That's a good topic. I like that. I don't know. I think as much as those surgeries can be really hard and tricky, I really enjoy them, especially like those lateral ones.
Yeah. They do
Yeah.
really well.
They do.
Really do. And so awesome. Well, thank you everyone for listening to our overtime chat. We hope you enjoyed our conversation today. So as always, make sure to subscribe on Apple Podcasts, Spotify, Amazon Music, and watch us on YouTube to stay up to date on all things sports medicine. If you like what you hear, please consider subscribing and leaving us a review or comment. You can also reach us by email at thesportsdocspod@gmail.com or find us on Instagram at thesportsdocpod and Twitter at thesportsdocpod. We love your feedback. Until next time.
Night.
Bye.